Let's see. We got everybody here. We got a few people here. All right, so we can go ahead and get started this morning. Good morning, everyone. For those of you who don't know me, my name is TJ Gal. I am a head and neck surgeon at the University of Kentucky. I do microvascular surgery and trauma, and this talk is a little bit about both. And so secondary mandibular reconstruction is basically when your primary mandibular repair or your primary mandibular reconstruction fails. What are your options? What are the causes of it? And how do you manage it? So the objectives today, again, it's a little hard to talk about secondary mandibular reconstruction without talking a little bit about primary reconstruction. We'll talk about the reasons that the primary reconstruction fails, and then we're going to go through some cases looking at the reasons for failures as well as the reconstructive principles. And so primary mandibular reconstruction, basic principles, what are we talking about? We're talking about fractures, we're talking about loss of mandible, gunshot wounds, advanced malignancies, even benign tumors or congenital deformities, and osteoradionecrosis, previous trauma care. So what we're trying to avoid is the crippled mandible. This is Andy Gump, which is an old cigar ad. And the thing about Andy Gump is, if you notice, he has no mandible. This is Andy Gump in real life. He has no projection. He's an oral cripple. He can't swallow. His speech is affected. And this is what we're trying to avoid. So the goals are a conglomeration of cosmesis and function. Cosmesis, we're talking about facial contour, certainly dental occlusion, and then we're trying to optimize speech and swallowing, and certainly in cancer surgery, neck vessel protection. And so the concepts are very simple. It's alignment of bony fragments, rigid fixation, replacement of lost bone, which is a requirement for the most part in anterior defects. It's a little more optional in lateral or posterior defects. What we do depends on the size or the length of the defect, whether it's a bone graft or some other sort of vascularized tissue. And then there's issues of dental rehabilitation. So you've got several basic types of reconstruction. You're talking about plate-only reconstruction, bone grafts, certainly free flaps, and then a little bit of the role of internal fixation. Plate-only reconstruction, really briefly, is sort of a antiquated technique when it was used a lot more in the era before microvascular surgery. A lot of these defects, if you're going to just put a plate, you probably should put no plate in there. You put a plate, it needs to be a load-bearing plate. It needs to tolerate the stresses of the reconstructive bed, meaning there needs to be soft tissue over it, because the scarring over that plate will eventually cause it to look like this. So these are plate-only reconstructions with no bone to support it, and so the soft tissues overlying it will frequently contract to the point that you will wind up seeing the plate. The other problem with load-bearing plates is that load is transient. Transient can be a couple of years, but eventually the work of the plate will either fracture or dislodge. And so another alternative is bone graft reconstruction. These are frequently staged procedures. There's a lot of scar contracture. If they've been treated with radiation and they've got bone loss, the blood supply is insufficient to supply the native mandible. So to put a non-vascularized bone graft is sometimes very, very challenging. But it's still good for small defects, particularly lateral defects. It's more challenging for anterior defects just because of the load-bearing requirements, but it can be done and can actually heal to the point where you can implant it. A couple of options for where to get the bone: anterior tibia. Anterior iliac crest is actually fairly well tolerated, much more so than, say, an iliac crest free flap, just because you go medially and there's less bone, but you can get a good bit of bone from both of these sites, as well as even the posterior tibia, posterior iliac crest. The cancellous bone, as you can see here, you'll compact it as much as possible. You can actually even load this in there, secure it around the plate. You've still got a load-bearing plate until this heals, but you can get a fair amount of bone in there. I would probably put a free flap in there personally, but it's an option, and it will heal to the point where you can actually put implants in it. So it's an option. It's probably preferentially used by oral surgeons, although they're certainly starting to do their share of free flaps as well. Free flaps for these sorts of large segmental defects is certainly state of the art. It's a primary reconstruction at the time of resection. You can even implant it primarily if you choose. Radiation is after the fact, from osteoradial necrosis, and allows for any sort of additional prosthetic reconstruction. It will tolerate that load. So the bulk of this talk is probably centered around free flap reconstruction of these secondary defects. As far as plates, most of these plates are locking reconstruction plates. These were initially 2.4 millimeter screws. We have a wide option of these, but these are basically external fixators that are placed internally. So if you have in your mind the old external fixators on the outside, or something that you would see in a long bone orthopedic prosthesis, that's what the principle of these are, but they're placed internally. So they don't need to be coapted to the bone like some of the smaller mandibular repair plates. As you can see, there's a wide option of them at this point. They've gotten smaller over time. The smaller the plate, the bigger the bone. The bigger the bone. If you're not using bone, you need a much bigger plate to bear the load of the mandible. And so again, if no bone is used, you need a big plate. They even have 2.7, even. With a bony free flap, I'll usually use a 2.0 locking reconstruction. I'd rather use a bigger bone and a smaller plate than a bigger plate and no bone. And so the smaller, and as far as fractures go, same thing goes, particularly with the edentulous mandible. The smaller the mandible, the bigger the plate. Intuitively, you would think a smaller mandible and it would take a smaller plate, but you actually need, the opposite is actually true. And these are larger locking reconstruction plates. So to recap, and this we'll get into the issues with secondary reconstruction: the poorer the bone, the greater the plate load, and therefore the bigger the plate. Better yet, take a better bone to use a smaller plate. Okay? So the object today is to talk about secondary mandibular reconstruction when all of this goes bad. So what are we meaning? So are we talking about reconstruction as a second procedure after ablative surgery? Well, not really, because that's kind of a staged procedure. Secondary alteration of the initial reconstruction? No, that's just sort of a revision or an augmentation. Reconstruction of the same defect with the same approach, i.e. a flap failed? Not really, that's just sort of another revision. What we're talking about is when the first reconstruction fails, necessitating another, usually more aggressive approach. So what are the causes of this? This, again, is a combination of, you generally have a bad fracture to start with, and to some degree, maybe a bad repair. In other words, your bad fracture is a severely comminuted fracture, gunshot wound, bone loss. There's fractured teeth in the fracture line, which can lead to infection if not managed appropriately, and then a bad repair. You choose the wrong plate, you don't reduce the fracture, and you get mobility, and that causes infection and plate displacement. And so these are people who will come in after their primary repair, and they've got pain, they've got drainage, they've got a mobile segment. You can see the hardware. Their occlusion is not how it was at the time of initial surgery. And these are your problem patients. These are the trauma patients who come back. Radiographically, when you're looking at your CT scans, you'll notice that you've got loose or displaced screws. You've got bone. You've got a space in the bone between the bone and the screw. You've got fractured plates. You've got bone loss, bone defects, just because the sequestrum is draining out. And so primary management of these is preferentially avoiding them. Adherence to basic principles of fracture repair. Once they're there, though, and they do happen, if you do a lot of this, it does happen. So I was able to accumulate a good-sized number of cases for this talk. But you need to assess the extent of the problem, looking at both physical exam as well as imaging. Make sure you get good imaging. 3D reconstructions are optimal. They're not always gotten primarily. So some of these are secondary reformats. So I apologize for that ahead of time. And then come up with the optimal plan. So what are the solutions? Do you just need a new plate? Do you have something that the bone can be salvaged and you can just put a new plate on it, or do you need new bone? It's very uncommon to salvage the primary plate. And sometimes the bone can be salvaged with a new plate, frequently augmented with some sort of superficial small bone graft. Sometimes the bone just can't be salvaged and needs to be removed. So usually at a minimum, you're going to need a new plate, usually a bigger plate than what you had in the first place, a more load-bearing plate. You may also need bone, whether that's a new plate and a bone graft or a new plate with a free flap, depends on the extent of the injury. So the goal is to restore occlusion, resolve the infection, and change whatever cosmesis that you need to deal with. So the cases we're going to look at are examples of this. We've got very simply a bad plate, bad bone, bad repair, unfortunately. Bad fractures are probably a frequent finding in these. And then you can get both. You get a bad fracture and a bad repair, lead to a bad problem. Very simply, bad plate. This is a gentleman with benign disease. This is an ameloblastoma, as you can see here, benign erosion of the mandible. This was resected and repaired with just a plate only. This was not my case. The resources weren't available, and the patient was treated, did well, and went back out into rural Kentucky for probably 4 or 5 years, and then came in with this, because the load of that plate is just not sustainable. And so you can see the plate fracture here. Simply, screws are still in place on both sides, but the load of the plate just was not sufficient. So this needs to be replaced with bone. This is a fibula, which we put in with a new plate, and that defect, and he's probably 10 years out now, doing well. And so the bottom line and the lesson out of this is very simply is plate-only repair is just not sustainable. Bony reconstruction is either preferential or eventually necessary if for some reason you're not doing it in the first place. That's a little bit of a big defect for a bone graft, free bone graft, but I would recommend it, some sort of vascular bone. Okay. This is a pretty bad mandible with what looks like a pretty good repair. You've got some lag screws that are holding in these smaller segments. You've got a comminuted mandible that was simplified with multiple plates, but there's a load bearing. This is a 2.0 reconstruction plate. It's a little bit of an older case, but pretty decent repair. Okay, so there it is radiographically, and there's also a subcondylar fracture here, which did fine. But already you can start to see a little bit of lucency of the bone. You can see some gaps in the segment, and he presented with plate exposure of these upper plates as well as pain. We took him back. We took those plates out. And now even more so, you can start to see this lucency in the bone. And this was continually draining. He actually started to drain out through the neck. The mandible was stable. This plate is still in place, but this was basically a non-union, an infected non-union. Okay. This was subsequently repaired. You can see we put a bigger plate, smaller plate, bigger plate, and this is a free bone graft because this is a pretty small segment. So once you stabilize it with a larger load-bearing plate, a little bit of bone in there is usually enough to get this to heal, and this actually did well, and he did fine. And so bad fractures don't always heal well. Adequate initial stabilization is the goal. Perhaps in hindsight, maybe a larger load-bearing plate would have been a better choice for a comminuted fracture like that. I didn't really see a reason to augment the bone in the first place, but secondarily, certainly that needs to be done. Bad repair. This is a little bit difficult to see on these images here. A little bit of motion, but you can see a fairly significant fracture here. Basically what this winds up is a 3D reconstruction of the same thing. It's an edentulous mandible, multiple fractures. Of a bucket handle. Okay. And this was the initial repair. I'm going to acknowledge it wasn't by me, but nonetheless, repair. Nice thin bone, so we'll put a nice thin plate on it. And there's a couple plates here. And she presented with persistent pain, swelling in this area. She didn't have any drainage, but you can see these segments aren't perfectly aligned, and there's some loose bone here. These screws are actually starting to work their way out. Okay, so initially, since the other side was okay, we thought it would be all right to leave it alone. Took it out, put a larger reconstruction plate in there. And she did fine, except then she started to complain of some left-sided pain. And you can see here on just a plain film, there's her larger recon plate, but now you can see that this plate has displaced because it was basically it was insufficient to bear the load. This bone and this repair was not, the bone was not completely healed, and therefore the bone was not sufficient to support the load with the repair. So this came out. And so we wound up taking that out and putting a larger reconstruction plate in. This is a simple representative, similar case where we just put the larger plate all the way across. We actually wound up with two large reconstruction plates in her. But you can see this is real thin bone, but this is a real big plate. Okay, and you're not even putting screws in along the fracture line there. You could make an argument to augment some of this bone with a bone graft. Okay, that's not a bad option, but this allowed this to heal. And again, the poorer the bone, the bigger the plate, which is sometimes not intuitive. Okay, and so this is the end point is probably proper management of the edentulous mandible fracture. Initially, not a great choice. And to re-emphasize the point, the thinner the bone, the bigger the plate. Bad fractures. That's a bad fracture. And you can see multiple comminuted segments put together that are all over the place. There's air in there. It's an open fracture. It was repaired elsewhere. There's some screws across trying to put these comminuted segments together. And sometimes it's better to just take them out and put a bone graft in. Just put some cancellous bone or even bone substitute. Tibial, I think is the one that's an option. Mineralized bone matrix for smaller defects. But not a bad choice of plate, good size plate, but you can see this, there's still some comminution. And this fracture actually extends up through here. And so the other thing is that this load-bearing plate probably doesn't extend far enough past the full fracture. And so this plate started to come out. Okay, here's, again, a poor reconstruction, but you can see the bone loss here. You can see that the fracture's still actually extending into here. So it was actually, there's probably only 2 screws on this side of the fracture. So they probably needed a longer plate. Okay, radiographically, after the repair, you can see bone loss. You can see, again, you can't really see the plate, but the plate probably doesn't, the plate only goes to about here. And so there's still bone loss from the comminuted fracture, and they probably needed a longer plate. But you can see the air around the screws, bone loss. And that's not going to support your repair. Okay, so this was replaced with a fibula. You can see a nice large bony segment here. This is healed up well. And here's his 3D reconstruction. Again, you can see the plate that was needed to fully support the load of the fracture needed to come across to here. So this is a much longer plate than what was initially placed. And that was probably the problem, is the plate didn't traverse the whole fracture. As you can see, a nice bony replacement there, and that's healed up nicely. There's another bad fracture. Again, you can see multiple comminuted segments. A little bit of artifact because he was intoxicated. But you can see on the initial fracture, he's got comminution here. This goes across, and this is just a little bit higher than this. So the goal here is to make sure you get all the way across this. I actually repaired this one myself. You can see he's got a nice long plate, a couple of smaller plates to simplify the fracture and support some of those comminuted segments. But this was when he presented with drainage out his neck, and you can see those comminuted segments just didn't survive, and there's bone loss and bone gap. The plate doesn't go all the way across that gap there, and that's what was draining. There's actually another plate that was used inferiorly to try to support this. This was the films don't really show the severity of that fracture. It was a terrible fracture. Not a terrible repair, but probably should have just chunked out a lot of that bone and replaced it. But we didn't, and so it started to drain. You can see here, along the repair, you start to see these gaps along your screws. You see bone loss. There's teeth in the fracture where they were starting to decay. That's frequently a nidus for these problems. Same thing here. You see all these the bone loss around the screws. That's going to cause infection and drainage. You can see here, and the plate is well across the fracture. There's a good load-bearing plate in there, and that bone just doesn't tolerate the burdens of healing. Probably too devascularized to survive. So we took all that out. He's got a slightly longer plate, slightly bigger plate, as well as a vascularized, that's fibula. You can see it here. And that bone looks much healthier. That's post-op, that's fibula right there, nicely coapted with the plate. And that's going to heal fine. He's done well. Okay, so the bottom line is bad fractures don't always heal, regardless of the repair. Sometimes want to try to put the native mandible segments back together, but sometimes they're too devascularized to tolerate it, and it probably is better to take them out and augment it with bone, or almost better to just leave it be than try to repair it, because they don't survive. So comminuted segments need to be addressed, but they can sometimes be, sometimes it works and then sometimes it doesn't. It works more often than you should. So if they're decent sized fragments, it's worth putting them in, but trying to piece those little small segments together is sometimes going to come back to haunt you. Okay. So this is a bad fracture with a bad repair. Okay. This is an initial injury. Okay. You see a fracture there. It's not a significantly comminuted issue, but there's a pretty good fracture there. And what's significant about this fracture is this tooth that's in the fracture line. Now, sometimes with teeth in the fracture line, intact teeth, the question is whether to remove them before or after your repair. And the bottom line is, if helping with your reduction, leave them in. You can pull them secondarily. If it's prohibiting your reduction, you take them out. If they're damaged like this, they need to come out. Now, this was not removed. And then he sort of disappeared, drug rehab type stuff. And then he came back to see me with a draining wound, malocclusion, and you can see that tooth wound up getting infected. It was subsequently removed, but it created a significant amount of infection. You can see this plate has completely dislodged. You see screws sitting out here. Okay, this bone this is an infected malunion that he had. So a relatively straightforward fracture that was just not addressed with a great plate. So it was a bad fracture in that it had teeth in the fracture line, but not a great repair, meaning the tooth wasn't addressed and probably needed a different plate, probably a longer plate to get across all of this. And once you take that tooth out, there is a little bit of a gap there, so you probably need to go with a bigger load-bearing plate. This isn't one of those where you can put the little mini plates in. This is not a mini plate repair. So you can see on 3D reconstruction, this is pre-op. This plate is at a different angle and trajectory from the mandible itself. The segment is not well aligned. You can actually see screws sticking out because this plate has completely come off. So this is what we found when we opened it up. We didn't really do anything to manipulate this plate. That's how it was. You can see that is not the normal shape of a mandible. You've got screws hanging out here, there, and everywhere. Took the plate out. You can see that that's all non-viable bone. So we took out that whole segment, put a larger plate across that. There's your fibula. When you do this, you're going to wind up with a soft tissue defect across the inside. So there is a skin paddle that'll go internally. This gets flipped in there, but that's your fibula. From about there to there's mandible there. And so there's your post-op reconstruction. Good sized plate, healthy bone, well healed. He subsequently did well. Depending on the motivation for implanting these secondarily, a lot of the oral surgeons would like a little bit more height, and so they'll either want to augment this with bone to restore that height, or you can actually just slide your fibula up a little bit higher. Otherwise, you're aligning this with the inferior border of the mandible for reconstructive purposes. You can see it there. And so the lessons are, it's important to deal with teeth in the fracture line. If you need help with that, collaboration with your oral surgery colleagues is key. Appropriate stabilization of the fractures, and by the time we saw this guy, it was too far gone to just address the fracture. We needed to address the bone. And so in conclusion, and we're a little early, but that's okay. Secondary mandibular reconstruction arises from a confluence of bad fractures and bad repairs. Sometimes this is beyond your control. You do everything right and it just doesn't heal right because it's a dirty fracture. But once you've addressed it, or once you've identified it and it happens, the best management is adequate stabilization with replacement of that bad bone. That can be something simple like a bone graft, frequently requires free tissue transfer. Any questions? Very good. Well, have a good rest of your morning, everyone.